Now we call upon Dr. MINU MATHEN, who with his handsome demeanor can cause many a heartburn. In addition to that, today's topic of his will be about wound burns. Welcome, Dr. MINU.
Thank you, Dr. Sai. Good morning, everyone. Thank you, Dr. Sudeep, for this opportunity. So, why is it? So, next 13 minutes, I am supposed to talk on IOL implantation problems. So, we basically believe mostly after IA, everything is done. And so, ഇത് ആ സ്ക്രീൻ ഇപ്പുറത്ത് ചേഞ്ച് ചെയ്യുന്ന വന്നു പക്ഷേ ഈ സ്ക്രീൻ അല്ല അതിനെന്താണ് ചെയ്യുന്നത് സ്ക്രീൻ മാറുന്നൊരു പരിപാടി ഉണ്ടോ ഫുൾ സ്ക്രീൻ ഇട്ടാൽ വരുമോ വന്നോ വന്നു ശരി ഇത് മാറ്റാൻ പറ്റത്തില്ലായിരിക്കും അല്ലേ പോട്ടെ okay, so we'll go ahead with this. We think that everything is fine, and then IOL, it's just IOL, it'll just go in. But then if we are not very careful with these IOLs, many things can happen. The whole game plan may change. See, like this. In this case, you can see that there is a PC run here. So an IOL is implanted. Instead of letting it go into the area where there is no PC rent or into the sulcus and later implanting into the bag, this directly goes into the area of PC rupture. And these are, when trainees do this, they have to be told that we need to keep cool. It takes some time for it before it falls. So during that time, have your presence of mind, hold it properly, and then when you have a PC rupture and if you want to land it safely, land it into the anterior chamber or on top of the rexus if you are sure, and then place the haptics gently into the capsular bag. See here again, just before aspirating the injecting the IOL, everything is fine. I've just injected the IOL into the capsular bag, and just after I go under the IOL and try to aspirate, I see two lines here now. So these two lines there should raise suspicion, which was not there before. So then I can zoom up and show you that these are two straight lines. But if I tilt the lens, this is changing shape. So that means this is not on the PC. So if a steady lines are there which don't change shape much, then think of PC. But then not all lines are PC lines. But then when you see additional lines like this after an IOL implantation, please make sure that you have not ruptured a capsule. And again, here this was a case referred from elsewhere. See, just a haptic which is sitting on the cornea, whole amputated haptic, and the lens is well inside the bag and it is fibrous. It is a long standing one. So sometimes many things, weird things can happen like this. The whole haptic breaks, people don't realize, and it is left inside the bag or whatever, and this finally comes into the anterior chamber and it sticks onto the cornea and it causes a corneal decompensation. So always inspect the haptic optic junction once the IOL is implanted into the bag, especially when the pupil is small. Please do retract the pupillary margin and look at the haptic optic junction after implantation. So here this is the regular problem which we face with this kind of injectors. See here, the tip of this injector is supposed to be here. So after some time of autoclaving and reusing, these become straighter, and then it overrides over the IOL, and then there creates at the bottleneck, or where there is the tightest part, you'll have to give more pressure, and once you give more pressure and it crosses that area, with that pressure it flies into the anterior chamber. So here you can notice that I'm introducing this with a lot of pressure, suddenly it goes in and it can hit onto the capsule. Here again, the 3-piece lens, see the orientation of the haptic. It is on to your right. Always it has to be on to the left, unless you do that, it will swing when you are injecting or underneath your optic, and if the bag is not very full, it will tear through the posterior capsule. And here again, this is another one where this overriding happens, and you can see that it's being forcefully injected. Now it goes into the bag, and you know that everybody will know that there is something wrong there because it is sitting in a very remote nasal area. I just retract it and then place it 90 degrees away from that area. Pupil is not fully dilated. If we want to make sure, put a iris retractor hook nasally and then retract and see. And foolishly, I don't see anything there, so I go very much into the bag and try to aspirate visco from there. It is totally unnecessary to go there and irrigate that area. So now you can see there are two strands which I get here, that is vitreous. So if there is some doubt of some peripheral thing, Go in with a, before aspirating, go in and see. Now you can see there's a small piscine area in the periphery, which can easily be left without a problem, and just rotate the IOL and place it in the opposite direction. So don't manipulate such areas which are doubtful if your IOL is very stable, and look at it by retracting or by putting an iris retractor hook. See, again, this many times happen with our Indian cartridges, which are not very properly suited. Many times they come in different sizes. So sometimes, otherwise also, you can have the haptics getting entangled between the flanges when you close. And this one, it has happened like that, and the haptic is not coming in, and even after retracting, it is not coming in, and it is broken. So if it is broken this much, then it will not stay centered. Only the 1 millimeter towards the tip, if it is gone, that's okay. Beyond that, it will decenter. So such a case, I will take it out of the bag, put sodium hyaluronate, open up the bag, place the other next standby. I always have another standby lens for all single piece IOLs, and a 3-piece IOL standby, and then it goes into the bag. Now the PC is protected. So the second instrument is used from the second hand side, from the paracentesis, and I use a long tipped Vana scissors from Apasami, no financial interest in this. It's kept only for cutting IOLs if required. And after that, I make sure that the section is extended to 3 to 3.2 millimeters for easy extraction. And I rotate this haptic towards the incision, and it folds over and is taken out without damaging the incision, because we need to not damage the incision much after we try to explant the IOL. So here again, this is another similar one where there is a IOL, but I am telling you that this is a femtorexis. So this is a femtorexis, and IOL goes in with a with force. And then what has happened is, if you notice here, nasally, where the IOL has gone in, the anterior capsule has ruptured. So I consider this is because it is a older version of the femtorexis, which may, or even now, if you have multiple laser points which are not opened and weakened areas near your rexis margin, and if you force it too much, sometimes it can break. And here, if you notice, I am loading it correct. It goes into the groove, or both sides are adjusted inside the groove. The tip of the haptic is inside the groove, and now it is moving freely. And if you want to test, we can just release the injector tip. The silicon sleeve, it moves freely, and the IOL remains free inside, means it is not. So it goes inside. Suddenly, the tip, the area of the cartridge nozzle, beyond the tip, just proximal to the tip, gives way. See this part, it opens up. That is again faulty injector issue. So identify where the haptic is engaged here. Sometimes it will just go in, but sometimes it is engaged between the silicon tip and the injector tip. And now identify where there is no haptic, and use 11 or 12 bead. You need to use some force. You have to have the anterior chamber full. Put sodium hyaluronate again, and then use a sharp one, and then with 2 or 3 strokes, you'll be able to easily open this tip, and you can release this. And once, if you see that the haptics are not damaged or cut, it can be placed very well in the capsular bag. This is again one more situation where I am showing this phaco because the rexis is fully intact. There is no rexis tear, and this is a single piece IOL which goes into the bag. So the importance of having the chamber fully filled up and the bag fully filled up is very, very important. So when the lens is pushed in a little more and the bag is not so full, this can happen. So we have hit on the periphery, and there is an inferior PC rupture. So initially, this line, I don't believe that this is a PC rupture, and I go aspirate the rest of the cortex which was still there in the bag. I thought it is some fold on the capsule. But then it is not changing position. It is actually confirmed that it is a large inferior posterior capsule rupture. And the same thing I do, which we did before. We put in sodium hyaluronate again, take out the IOL, dial it out of the bag, bring it into the anterior chamber, cut it, explant it. Before that, place a 3-piece lens. Now no lens goes into the bag here because it's a very large inferior PC lens. So a 3-piece IOL, which I have as backup. So always have a 3-piece IOL and a single piece similar powered IOL as backup in every case, which I do nowadays in every case. So here this IOL comes out of the bag, and a 3-piece goes into the sulcus over the rexis margin, which I am sure that it is completely intact. And the same thing. So now after this, moving on to wound burn, which we don't generally see nowadays because of the advancement in the ultrasound delivery system and the machine, higher end machines, but still it can happen. So when it happens, it is odd sometimes. So when you are focusing very much on your phaco, we will not get time to look at the incision. See, it is always said, many times we say keep a look at your incision also, but when you are focusing at the tip of your phaco probe, it is difficult to keep looking at this one. When it hydrates also, it will look white, and your sleeve is also white. You don't see most of the times. So sometimes when you finish off only, you will realize that there is a burn, or this is a small burn which is just towards the outer side, and so this will close because the inner lip is free, and sometimes it will extend all over the incision, and it may be very difficult to close. So make sure that your incisions are large enough. I definitely, if it is a 2.8 incision, I make sure that I go just before 2 millimeters, 1.75 millimeters at least into the clear cornea, so that even if you get a burn at some location, there is other lot of cornea left to hold, and it will hold. But if it is a very short incision and if it burns, it will be very difficult to stop leaking, and you will have to suture and multiple sutures to prevent leak, and it will induce a lot of astigmatism also. So incision is very crucial. A single plane is fine. Two plane is desired in most of these cases, and you can notice in some cases, if you put a 2.2, if you're told that it is 2.2, sometimes you feel that your sleeve is tight in there. So the incisions are not, maybe your crescent blade, all the blades do not conform to the size which they're talking about. Your sleeves become too elastic and enlarged, or many times I have seen Dr. Bobby Osher tell that he makes an internal incision 0.1 more. 2.2 on the outer, 2.4 on the inner. Nowadays people have moved on to 2.3. I do 2.4. So that is safe. It should not leak for sure, but it should not overlock also. And when you are moving, tip should always, the sleeve should always get fluid going through. So if you're tipping it up without knowing, you won't realize. You'll be focusing on the phaco. You'll be forcing the needle towards the side. You'll be pressing it down. You'll be pushing it up. All the time, if you're delivering energy through that also, there is no flow through that area, and directly it can burn that area. And that is what you can see here, that when I am moving towards one side, you can notice I'm just for the sake of showing, I'm showing. See, moving towards one side, it stops the irrigation through that point. Another thing is putting in a lot of dispersive viscoelastic. Dispersive viscoelastic, again, after putting it in, I always put sodium hyaluronate just over the IOL, because you don't want dispersive viscoelastic where you do phaco. It is anyway going to get aspirated. So if that goes into the phaco tip and it gets blocked, and suddenly you give energy and there is no outflow, it burns. And same thing happens if the tip is blocked and there is no flow inside, and then still you keep on giving energy, and that again burns. So make sure there is always a flow backwards into the chamber and through the sleeve. And so once it is burned and it doesn't close by hydration, do not hesitate to suture. See, if it is a small one and if it is a 2.2, you can always try a mattress suture or even a horizontal suture. Many times it will close. But sometimes if it doesn't, see, after hydration also, it's a small incision, but then still after multiple hydration attempts, make sure on the table it doesn't leak. And even if it is small and one suture does not hold, please put multiple sutures, because there is no harm putting more sutures and taking it off later. But the difficulty will be when there is a leak and you get hypertonia or a flat chamber, or mostly endophthalmitis or infection because of this leak. So whenever you're in doubt with the incision, even if you don't see a very obvious burn and it's all hydrated and it's white looking, always put suture. Here again, I am pressing. You should press on the other side and see whether this is leak proof. If it is not, please put multiple sutures, and it has to be tight. There is no point in thinking about astigmatism at this point of time, because the main concern is to close the wound. Thank you very much.
Thank you very much, Dr. MINU MATHEN. One good thing I liked about it was, do not trust all lines to have integrity, because we have to read between the lines. So that is one thing.